Hello friends, welcome back to my channel with a new video, and this is the continuation of the difficult airway series. We have already finished two videos. This is the third video, and we left out at the steps of the difficult airway. So the step one will be the pre-oxygenation and induction of anesthesia. So, as we know, pre-oxygenation should be done in the head elevated position if possible, using NIV with pressure support between 5 to 15 and PEEP between 6 to 8. Tidal volume between 6 to 8 uh, ml per kg and PEEP of around 5. So, pressure support, uh, expected tidal volume, and PEEP. Nasal cannula with oxygen of 15 liters may be used in addition when there is a mask leak, or HFNO with 70 liters per minute of oxygen flow. So this is the minimum criteria for pre-oxygenation. Pre-intubation fluid bolus of about 500 ml of crystalloid, preferably say normal saline, in absence of cardiogenic pulmonary edema. Patient should be anesthetized using ketamine or etomidate and neuromuscular blocking agent, either succinylcholine or rocuronium. And IPPV may be performed using bag mask wall with a reservoir bag using external PEEP of around 5 to 10, or IPPV using ventilator maintaining a cricoid pressure all throughout, and it should be given, but it may be partially or completely released if ventilation is inadequate. So if the patient is getting ventilated, that means that you're allowing that air to go through the vocal cords. Now second step is laryngoscopy and tracheal intubation. So if mask ventilation is successful, proceed to intubation using direct or video laryngoscope. And here, if you remember, we had some evidence towards video laryngoscopy, the success of first pass attempts with the help of video laryngoscopy. Nasal oxygen using oxygen flow of about 15 liters per minute, or HFNO, which should be used and it should be continued. Do not exceed more than 2 attempts at intubation, and repeat an attempt only if the oxygen saturation is more than or equal to 95%. And mask ventilation should be performed between the attempts. Optimize the position, use external laryngeal manipulations, partially or completely release the cricoid pressure to optimize the laryngoscopic view if required, and use a bougie or stylet if it is required. And between attempts at intubation, consider changing the device or technique rather than repeating the same technique. So, in few centers, use of stylet is like a blanket protocol, but in our setting, we use stylet only when we kind of deemed necessary. Bougie also in situations where we cannot visualize the larynx at one go, in the cases of anterior larynx. So the protocols might change from center to center. Maintain the depth of anesthesia throughout the intubation attempts. If mask ventilation is not possible, single attempt at intubation could be made, provided that the saturation is more than 95 or equal to 95%. And after the intubation, confirm the ET tube position using continuous capnography along with the clinical method. So this is mandatory. Now coming to the step 3, that is insert SAD or supraglottic airway device to maintain the oxygenation. If 2 attempts at the intubation fails, or a single attempt at intubation following an unsuccessful mask ventilation fails, insert SAD, preferably a second generation device, and ventilate to maintain the oxygenation. Not more than 2 attempts should be made to insert an SAD, and only if the saturation is more than or equal to 95%. Nasal oxygen using oxygen flow of around 15 liters per minute or HFNO, which should be continued during the SAD insertion. Consider using a different type or size of SAD during the second attempt and maintain the depth of anesthesia throughout the insertion attempts. Once the SAD is successful and oxygenation is maintained, consider performing a percutaneous or surgical tracheostomy for further airway management. Intubation through the SAD may be considered, but only under vision using a flexible fiber optic bronchoscope. And intubation should not be attempted blindly through the SAD if a bronchoscope and the expertise to use it are unavailable. So there, there are very clear cut messages as far as the difficult airway or the use of SAD and the intubation following that are concerned. The step 4 is rescue face mask ventilation. So if ventilation through the SAD fails, continue the nasal oxygen using oxygen flow of about 15 liters per minute or HFNO. Ensure complete neuromuscular blockade. Repeat a muscle relaxant if it is required. And in this case, obviously, as I said, I would kind of prefer rocuronium. If not, then succinylcholine. Give one final attempt at face mask ventilation using optimal technique and adjunts. And if rescue face mask ventilation is successful, then you may proceed with a percutaneous or surgical tracheostomy. So that is only when you are successfully ventilating the patient through the face mask. However, if rescue face mask is unsuccessful, there is a complete ventilation failure, and in that case continue nasal oxygen using oxygen flow of 15 liters or HFNO, and of course call for additional help. Immediately start performing emergency cricothyroidotomy before the patient desaturates further. So there are very clear cut guidelines as to when we should go ahead with the fiber optic bronchoscope, with surgical or percutaneous tracheostomy, or with emergency cricothyroidotomy. And the fifth step is emergency cricothyroidotomy or FONA. So perform emergency cricothyroidotomy using needle or surgical cricothyroidotomy based on familiarity and availability of the equipment. If needle cricothyroidotomy is performed, maintain oxygenation using a pressure regulated jet ventilation until a tracheostomy is performed. If a wide bore cannula cricothyroidotomy set has been used or an ET tube has been passed through the front of the neck, continue ventilation manually or using a ventilator circuit. So these are the AIDAA 2016 guidelines for tracheal intubation in the intensive care, and we have discussed exactly those 5 steps. So this is step 1, the step 2, the step 3 when there is a failed intubation, then when there is a failed ventilation through SAD, if there is complete ventilator failure, and of course you are going ahead with something like emergency cricothyroidotomy or FONA. So this is we are talking about the rapid sequence induction or rapid sequence intubation, which is a technique that helps secure a patient's airway quickly and safely while reducing the risk of pulmonary aspiration. So as I've already stressed upon, that this is a technique for mainly to prevent risk of aspiration, and it is obviously rapid. So there is a 7P approach for RSI, and it starts with preparation, pre-oxygenation, pre-treatment, paralysis with induction, protection and positioning, placement of the tube in the trachea, and post-intubation management. So these are the 7 P's which forms or the mainstay for RSI. So when you prepare for intubation, you pre-oxygenate. There is a checklist for the RSI which is talked through. Give induction agent, give neuromuscular blocking agent, and of course the patient will have an apneic oxygenation. Apply the cricoid pressure when there is loss of consciousness. Prepare a laryngoscope, intubate the patient, confirm the tube placement. After the tube is inserted, remove the cricoid pressure. Ventilation is established and tube is secured, and of course, proceed for the post intubation patient assessment. So, just we are talking here about the cricoid pressure. So, 10 Newton of the force which is applied by the thumb and the index finger of an assistant, which is increased to 30 Newton once the patient is unconscious. So 10 Newton is actually equivalent to around 1 kg of pressure. So as you could see in this diagram, so this is the first and the second tracheal ring, this is the cricoid cartilage, and this is the thyroid cartilage. So our pressure is exactly at the cricoid pressure and with the index finger and the thumb. So it is at the level of the cricoid cartilage. This pressure is maintained until endotracheal tube is confirmed, and after that the cricoid pressure is released. Now there is something called as a modified RSI, which is a variation of the traditional RSI technique characterized by incorporating elements like pre-oxygenation, cricoid pressure and controlled ventilation during the induction process, aiming to improve safety and intubation conditions, especially in patients at the risk of or high risk of aspiration. So this is a modified RSI which involves controlled ventilation. So these are the components of modified RSI in the form of pre-oxygenation, cricoid pressure, controlled ventilation, which attempts to ventilate the patient gently while maintaining cricoid pressure, which can help to prevent hypoxia and improve the oxygenation. Choice of the induction agents using the drugs like propofol or ketamine, which offer favorable intubating conditions or cardiovascular stability, instead of relying solely on thiopentol and suxamethonium. So, but in this case, probably I would prefer ketamine and of course rocuronium instead of suxamethonium due to its favorable side effect profile. And the most important thing, I think here we should the message which I want to convey is availability of the reversal agent for rocuronium in the form of sugamadex. So because sugamadex is available, probably my agent will be rocuronium and not suxamethonium. Why use modified RSI? It should improve the safety. So the modifications in the modified RSI aims to reduce the risk of complications associated with traditional RSI such as hypoxia, aspiration and hemodynamic instability. Secondly, enhanced intubation conditions. By optimizing oxygenation and ventilation, modified RSI can improve the conditions for successful intubation, especially in patients with difficult airways. And adaptability. Modified RSI allows for greater flexibility in adapting the intubation technique to the specific needs of the patient and the clinical situations. So these are some of the advantages of modified RSI. So the common modifications is omitting the placement of an esophageal tube, supine or ramped position, titrating the dose of induction agent to loss of consciousness, use of propofol, ketamine, midazolam or etomidate to induce anesthesia, of course use of high dose of rocuronium as a neuroblocking agent, and omitting the cricoid pressure. Now we will talk about something like delayed sequence intubation. So we had a detailed discussion on RSI, We also had couple of slides on modified RSI, and of course now here we are talking about DSI or delayed sequence intubation, which is an alternative to RSI that prioritizes pre-oxygenation by using a sedative agent, most commonly ketamine, to allow patients to tolerate oxygen delivery before paralysis and intubation, especially in an agitated or difficult to oxygenate patient. So, such kind of patients who are commonly encountered in the emergency department, who are agitated, difficult to oxygenate, where you sedate this patient first and then wait for the response. Most of the times, you may find that the patient, when is shifted to ICU, you may not actually have a need for intubation. Now, the process of DSI, as I said, starts with sedation. So, patient is sedated with an agent that preserves airway reflexes and respiratory drive, like ketamine. You pre-oxygenate this patient with high flow oxygen, either a non-rebreathing mask or CPAP. Paralysis and intubation, once the adequate pre-oxygenation is achieved, of course you give a paralytic agent and the patient is intubated. Now, the advantages of DSI is, of course, it improves the oxygenation. So, it allows for better pre oxygenation, potentially reducing the risk of desaturation during the intubation process. Safety can be in the form of in the patients who are agitated or combative and cannot tolerate standard pre oxygenation methods. And of course, this decreased risk of aspiration where we have a patient who is not NBM. Now, when do we consider DSI? As I said, especially in an emergency department where you encounter a agitated or a combative patient, patients who are difficult to pre-oxygenate, patients with high risk of desaturation during intubation, and of course, patients with altered mental status. So, these are few of the specific conditions where you may prefer DSI. So, now talking about the position during intubation, and this is so very important that the position of the patient will allow the operator for the first pass success of intubation. So it's a sniffing position where it is alignment of the oral, pharyngeal, and laryngeal axes, which is crucial for clear view during laryngoscopy, and it is achieved by elevating the patient's head, extending the patient's head at the neck, and aligning the ears horizontally with the sternal notch. So, this is how we achieve the sniffing position. There is a concept called as HELP, that is head elevated laryngoscopy position. The purpose of this position is particularly which is helpful for obese patients or those with anticipated airway difficulties, and it is achieved by elevation of upper torso using a commercially available performed triangular elevation pillow, elevating the head end of the table, or by stacking folded sheets under the upper torso. So this is how the classic sniffing position is looks like. So as you could see that there is horizontally alignment of uh, this axis. There is the open neck, and there is this axis which is aligned as a horizontal axis, the ear and the sternal notch, and of course there is a headrest. There is extension at the atlanto-occipital joint and flexion of the lower cervical C6 to C7. Well, this is a very classical sniffing position which is given in adults. Okay, now this is the HELP position. As you could see that this patient is obese, and this is head elevated laryngoscopy position, and the patient is reverse Trendelenburg position, where the patient is given a reverse Trendelenburg position. So There is another position by the name of 25 degrees backup position, which is also described as a simple and useful technique in improving the glottic view and intubation success with reduction in intubation time compared to ramped up and sniffing positions, and modified ramped position where it is achieved by elevating the patient's shoulders, extending the patient's head, and using a special pillow which can improve the intubating conditions, especially for obese female patients. So, these are the different positions which we use for the patients, especially who are adults, and we are talking about adult intubation, along with a special situation where the patients are obese or obese female patients. So I think that's all for now, and let us have the last and the fourth video on the airway next time. Till then, bye bye. Thank you very much.